Hi, I'm Dr. Bill Gradishar, Professor of Medicine at Northwestern University, and I'm pleased to join you on this Yerbba YouTube video that addresses the issue of why cancer comes back. If you'd like to get more information about personalized treatment paths, including the different therapies that are available that might be appropriate for your situation, tailored to your tumor biology and health profile, you can get a Yerbba report which breaks down chemotherapy regimens, endocrine treatments, and other combinations, and provides specific information that may be appropriate for your case. And you also have an opportunity to interact with Yerbba's medical experts directly for evidence-based answers about your options, recurrence risk, or side effects from the therapy you have by going to yerbba.com. So this is always a very traumatic discussion with a patient who has been treated for early stage breast cancer, and then at some later time point in certain patients the disease rears its head again and we have recurrent disease or metastatic disease. And a number of questions come up and a number of emotions are expressed. Obviously in this situation, not only are patients scared, they're angry, they want to know if the therapy they had was useless, if it didn't affect their overall outcome and just exposed them to side effects. All of these and many other issues come up in this kind of discussion. And they also want to know if you're going to be treating them with something else, how do you know that's going to be effective? So first question is, why does cancer come back? The only way the cancer can come back is if it didn't completely 100% disappear with the initial treatment. Now, of course, when a surgeon does surgery, they take out a breast mass, they get clear margins, everything's gone. And the old notion was, this goes back a long, long time ago, was, okay, the cancer's cured. But the reality is we understand more about the biology of the disease. Tumor cells circulate in the bloodstream, even though we may not be able to have any clinical evidence of that based on a clinical exam, or even if one were appropriately getting imaging studies of other parts of the body, you wouldn't see this, or blood tests may not detect anything that's abnormal. Those are all the reasons we don't typically do those kinds of tests in patients with early stage breast cancer. So the fact that we know that in certain patients circulating tumor cells exist and they can sit quietly and do nothing for years is what accounts for the recurrence problem that some patients experience, in some cases many years later. And there is a difference between subtypes of breast cancer and the risk of recurrence and when it happens. In patients with HER2-positive breast cancer or triple-negative breast cancer, the chances of recurrence tend to peak within the first couple of years and then diminish towards zero thereafter. So in those kinds of breast cancers, if you get beyond the first couple of years, the chances of a recurrence is much, much lower. However, in patients with hormone-sensitive breast cancer, those are tumors that have estrogen and progesterone receptors present, the recurrence risk can extend out to 5 and 10 and 15 years, even 20 years later. The risk is not high, or another way of putting it, if you take a whole bunch of patients and you follow them out for 20 years, the majority of them will be cured with early stage disease. However, with each time point, 5, 10, 15, 20 years, there are still patients with hormone-sensitive breast cancer who are recurring. And this is because, again, there may be tumor cells that lie dormant for an extended period of time. How they do that, why they do that, and where they sit, we don't know or understand completely. The bone marrow is sometimes thought as one of the sites where cells can lie dormant. And for reasons we also don't understand, they become active again. And it's when that activity emerges that we find a recurrence, and we have recurrent or metastatic disease that we have to discuss and develop a treatment plan for. So again, the different subtypes may lead to a different pattern of recurrence, and the risk of the disease coming back at some later time point is always predicated based on what the situation was when the patient was initially diagnosed. So a tiny tumor, no nodes, compared to a big tumor with lots of nodes, the risk of a later recurrence is going to be much higher in a patient that has bulkier or a higher volume of disease. So there are a number of different ways that we can think about this. So why do these recurrences occur? Why wasn't therapy completely effective? Well, I indicated that, dormancy is one issue, and, one of the questions comes up, well, why didn't the therapy get there? Why did my immune system affect that? So there's a number of different activities that go on in these niches where these tumor cells can exist. The extracellular matrix, which is the composition or the sort of foundation that cells sit in. There can be growth factors in that environment that either stimulate or allow tumor cells to remain dormant. The immune system can be fooled by certain markers on tumor cells that basically shut off the immune system so that it doesn't recognize the tumor cells. So there's a number of different interactions that have been postulated or speculated upon, which could account for why tumor cells, even in small numbers, aren't completely eradicated. The other thing that should be mentioned too is sometimes when a breast cancer becomes active again at some later time point, we always biopsy it to make sure there is similar markers to what was identified at the original diagnosis. Sometimes a breast cancer that was hormone receptor positive upon recurrence can be less hormone receptor positive or negative. So it may be that the initial therapy eradicated a certain clone of cells, and not all tumor cells are 100% the same in a breast cancer. The cells that remain that sit quietly may have different features, and when they emerge, you want to know what they are so that you can design the appropriate therapy. So again, breast cancer recurrences can happen. It is dependent on your situation at the original diagnosis in terms of the likelihood that that might happen. But we always remain vigilant, even many years later, for anything that may suggest a recurrence. And should it happen, we, of course, rebiopsy and make a treatment plan accordingly, depending on the patient's situation at that time. One of the questions that often comes up, and it's sort of baked in when you talk to patients, they want to know if what they went through at the outset with their original therapy failed. And I don't know that I would view it as a failure, but it was not completely effective, obviously, if you had a recurrence, because all the tumor cells, 100%, were not eradicated. Some of them may sit quietly and do nothing. So, of course, we're trying to understand who are the patients that may have a somewhat higher risk of late recurrences or a recurrence in general. And of course, we look at the original biology of the tumor, the size, the nodes, the markers, but we're now looking, in a sense, under the hood, looking at molecular features, utilizing circulating tumor DNA, not only to get a hint of something that may be changing or the presence of circulating tumor DNA when it was not present before, or looking for mutations that may emerge that suggest that there's something evolving with an underlying cancer. So these are strategies that are certainly being employed in patients with advanced disease, but we're also starting to look at this as a potential strategy even in patients with early stage disease, trying to get hints of evidence that there may still be tumor cells or a problem that could be brewing. And by doing so, hopefully in the future, we'll be able to identify the patients at highest risk for a recurrence, and above and beyond the therapy they received, which we view as standard, there may be other strategies to further reduce the risk based on certain molecular features that we see present in the blood. That is not standard of care at this time. So in this discussion, what I've tried to convey to you is that cancer can return at a later time point. It happens dependent to a degree on the circumstances the patient experienced at the outset. In other words, the stage of disease, the molecular markers of the tumor, these features characterize the individual patient risk based on clinical features and those molecular markers, hormone receptors, HER2. We also know that there can be dormancy of tumor cells, even though all the disease that we can clinically identify has been eradicated. Tumor cells can still circulate in the bloodstream and sit somewhere in the body and do nothing for years and then become active. And the strategies we're now exploring is whether or not certain molecular tests may identify those patients at the highest risk. And then, of course, once knowing that, can we develop strategies that will minimize the risk in those patients for a recurrence at some later time point. So I hope you enjoyed this discussion. If you'd like more information, go to Yerbba.com. If you'd like to learn more detailed information about your clinical situation as well as the therapeutic options, the pros and cons of any particular therapy, again, go to Yerbba.com. I look forward to speaking to you again in the future. Thank you.